This is a comment piece by Paul Drew, Senior Lecturer in Adult Nursing, Birmingham City University. The audio is automated when it comes to cardiac arrest. Why a student sold a story of saving lives. Are we setting staff and students up to fail by not discussing the reality of in-hospital cardiac arrests? As potential future nurses, we came into this profession to help people and to make them better. Through our training, we then realize that we can't always make patients better, but we can help them through their journey, be there to treat what we can, talk to and console, and sometimes just be there. So why is it that when it comes to cardiac arrests, student nurses and staff are sold a story of saving lives? The overwhelming pressure and responsibility of identifying a cardiac arrest, calling for help and starting cardiopulmonary resuscitation, CPR, or else your patient will die. I have been teaching CPR for over 10 years, and as an ex-resuscitation officer and advanced life support, ALS instructor, CPR is just as overwhelming for qualified nursing and medical staff, let alone our student nurses. Hospital television programs teach us that CPR will always save our patients' lives. We teach CPR as part of mandatory training before students attend placement, which normally ends without the outcome being discussed. And so, naturally, when the patient doesn't survive a cardiac arrest, students and staff express a fear and anxiety of why didn't it work? The reality is very different and should be discussed more openly. I feel this may reduce the anxieties of cardiac arrest and improve the quality of the situation, the quality of CPR, aid in real-time training, and ultimately the outcome of the cardiac arrest. In the past, staff and students have discussed their experiences of cardiac arrests, using phrases like organized chaos, but it doesn't need to be like this. One reason why staff are so frantic around cardiac arrest is the thought that speed saves lives, quick help, quick CPR, quick recovery. But in most cases, this slows the situation down due to errors, miscommunication, and bumping into each other, especially if too many staff arrive. We teach in hospital basic life support once a year for staff and students, but we are surprised that staff and students panic and forget what to do. Ward-based cardiac arrests are not that common, and staff can go a year or two without seeing one. So how can we support our staff and students in managing the anxiety of cardiac arrests? Practice, simulation, and training. Practice the skill. I have changed how we deliver basic life support to our students. We use a flip learning approach, with detailed videos being made available weeks in advance that explain and rationalize what is happening, why it is happening, and how to use the equipment. This allows students to mentally prepare for the basic life support session and gain some underpinning knowledge of the topic and what to expect from the session. This material is available throughout the year to allow students to review, update, and reflect on practice. This kind of format could be implemented into the clinical setting as part of mandatory training, but also as an easy access resource to allow staff to be exposed to an event and how they may be run, simulate the event. Simulation is not a new concept, but if used correctly, it can be quick and impactful and help to make an uncommon situation more familiar. I used to run impromptu ward-based simulation activities. In agreement with the lead nurses and the resuscitation committee, we would create an impromptu cardiac arrest simulation on the ward to allow staff to get used to an event, apply what they know or have learnt into practice, debrief, and reflect. This aided in making the skill more real and moving the learnt skill to a familiar memory and so less likely to be forgotten. Students would also benefit from cardiac arrest simulation at university, especially when the Nursing and Midwifery Council recommends simulation is an integral part of higher education learning. Training in the skill, pathophysiology, and epidemiology. This allows staff and students to understand and rationalize why high-quality chest compressions are so important. Why applying that automated external defibrillator, AED, early is safe, and so withdrawing the pressures we put on ourselves that we have not performed correctly, and a patient dying is somehow our fault. In 2022 to 23, The National Cardiac Arrest Audit published data showing that 23% of patients survived a cardiac arrest. Non-shockable cardiac arrests, such as pulseless electrical activity and asystole, which conditions hold a very poor prognosis, account for over 70% of in-hospital cardiac arrests. This is not because we are poor at CPR, but because most of our patients will have multiple things going on, elderly with comorbidities, and without a do not attempt CPR decision being discussed. These patients would have a higher chance of a non-shockable cardiac arrest and so less chance of surviving one. So don't put the pressure on yourself. Do your best. Identify a cardiac arrest. Call for help and start high-quality chest compressions. Debrief and reflect. And if the patient does not survive, understand why. It's a team effort. The full version of this article, with references, can be found at nursingtimes.net under the category Education and Training, along with our AI search facility, Ask Nursing Times, which allows you to explore the subject further. Thank you for listening.